Is this TV on?
Yeah.
Okay. Can't hear.
Download. But don't worry, this is going to be a very hands-on, interactive workshop, thanks to the wonderful Dr. Landau, who will be working with you closely on practicing the manipulations of the various congenital deformities, performing the Ortolani and Barlow maneuver on the baby hippie, and each of you will be applying an above-knee serial plaster cast. There are several handouts and videotapes posted on Canvas associated with this workshop. Particularly manipulation techniques handout is helpful. And I would definitely look at the videos. One is on metatarsus adductus and calcaneal valgus. A second one is on TEV. And many students say that they like to practice on their little son or daughter, or on a niece or nephew, or even on a doll, simultaneously while watching the recording of me performing the manipulation. Also, you will get some time before you do the task. Dr. Landau will give you some time to practice just before you test on this. For some of you, that won't be for a few weeks. So let's get started with the definition of serial casting. As the word serial implies, this is a series of casts, not just one cast. And it is the application and then the reapplication of plaster and or fiberglass to a body part for sequential, gradual correction of a congenital foot deformity. Here is a list of some of the indications for serial casting. This would include metatarsus adductus, calcaneal valgus, TEV, convex pes valgus, but as we learned last year in PP1, convex pes valgus or vertical tail, you will do initial casting, but that always requires surgical intervention. Internal tibial torsion, you can do an above-knee serial cast to correct this, but many of us just use splinting for those cases where we don't think it will self-correct. And another one is ankle equinus. This may be congenital in nature. I have seen babies that were born with tibial cords, not the whole clubfoot deformity that I have done serial casting. Or some is an acquired ankle equinus due to children that persistently toe walk, and that will be another lecture I will cover. When is the best time to serial cast? Well, for metatarsus adductus and calcaneal valgus, and even ITT, between 4 to 9 months of age. I certainly would wait a little bit later on ITT because a lot of self-correction can happen in that first year. But for metatarsus adductus, calcaneal valgus, if you see that it's moderate, by 4 months I would start casting them. TEV and convex pes valgus, that's different. That you want to start as soon as possible, within the first week of life. And in both of those, it is usually only a maximum of 8 casts. After that, surgical intervention if you do not get the correction. For a congenital ankle equinus, if it's severe and it's congenital, you can start in the first year of life. An acquired ankle equinus, that's noted in older child, like a 2 or 3 year old, you can do serial casting. And studies show that it becomes impractical after about age 7. So that's the upper limit. I always get the question, how long should you cast for metatarsus adductus and calcaneal valgus? Well, that really depends on the severity of the deformity. But in my experience, I would say about 8 weeks would be a good estimate. But always tell the parent, if they think it'll be longer, tell them longer, because if you say 8 weeks, they will hold you to the 8 weeks, and if you want to put one more cast on, they're going to be kind of disappointed. So if I say 8 weeks, if I think it's 8 weeks, I'll probably tell them 10 weeks. You've done a little earlier than we've been very happy. Okay, what materials are needed for serial casting? Some people use betadine solution as a skin adherent. Some people use tincture of benzoin as a skin adherent. Some people don't use any skin adherent. I can tell you that if the child has atopic dermatitis, this will flare often with a serial plaster cast, so I usually will use a thin layer of a moderate potency topical corticosteroid and then apply the casting material to prevent a flare of the atopic dermatitis on the legs. After applying the skin adherent, Then I use stockinette and or Surgitube. Surgitube can come in 1.5, 1.25 inch width. The stockinette, usually the smallest that is, this is the yellowish one, is 2 inches. So if you have a bigger baby, you might do 2 inches on the leg and maybe 1.5 inch on the smaller, narrower foot. Then cast padding, this is also a preference. I like the Johnson & Johnson Specialist cast padding. I think it molds better. Other people like resin. That's an individual preference. And then 2 to 3 inch roll, 2 or 3 inch. You know, if it's a small baby, it's going to be all 2 inch. If it's a somewhat larger baby, it might be 2 inch on the foot and 3 inch on the leg. You would like extra fast setting. You want this to set quickly. You need drapes for the floor, not to make a mess in the office, and a basin for warm water, not cold and not hot, tepid water. And whatever congenital deformity you are correcting, ideally you want to manipulate the foot for about 5 to 10 minutes before applying the cast material. Now, if the baby's already crying, that for me will probably be only 5 minutes of manipulation, because I really need them cooperative when I actually have the materials on the foot and leg and I'm correcting the deformity. So here, a student is applying the betadine solution, as we see here. And here is on video, this is a clubfoot baby, so the student is applying a thin layer of padding from the tips of the toes all the way to the groin. I don't apply the betadine to the second leg, because what happens is if you do the cast on the left, if you've got betadine on the right, then the right leg touches the left calf, and then you get those purple spots on the leg. So just do one leg at a time. And make sure you go all the way up proximally to the groin. These tend to kind of come down a little bit in the process, so you're not going to apply the plaster that high. I do put the hip padding quite close to the proximal end of the thigh. The next step after the betadine is to apply 2 separate pieces of Surgitube and or stockinette. Now here's a smaller baby, so the student is applying one longer piece of 1.5 inch stockinette on the leg, and then a separate shorter piece, 1.25 inch of Surgitube on the foot, leaving the anterior ankle free of the stockinette or Surgitube. The reason we do this with serial casting, sometimes it gets a little bulky on the anterior ankle, and that can cause wrinkling and skin irritation, so I like to do it in 2 separate pieces. So here, again, the student is applying. Now, this is a somewhat bigger baby, the 2 inch stockinette on this baby's leg, as we see here. And then we put a separate piece on the foot, and now I am wrapping here the 2 inch stockinette 4 to 5 times around the forefoot. I like to make it somewhat distal, so we just see the tips of the toes. I am also wrapping close to the leg. I am not 8-10 inches away from the leg when I wrap, because then you lose control of the rope. Now here, I tore the padding, and I resumed wrapping the padding proximally. This is a good idea if there's any swelling that occurs. The swelling will go into the area where you tore the padding. So instead of having one continuous roll of padding all the way up the leg, which can sometimes with swelling cause a tourniquet effect, and then you get swelling up in the groin, this is a better way to just allow it somewhere in the mid-leg. This applies more to trauma casts and not to serial casting. But it's a good idea for any cast you put on. As you can see, I'm working up. I'm only doing a little less padding, 2 to 3 layers in the middle of the leg, and then I'm putting more padding on the proximal end of the leg. Okay? And every time I apply the padding, I want to make sure I look behind me to see where the padding is. Also, I lift up the foot. Oops, I see the skin tone, which means in that spot there was only one area of padding. That's not enough. So we always have to lift our foot, the baby's foot, and look at the back of the heel, especially, to make sure that you have enough padding. If you do not have the heel covered because you didn't look on the back of the heel, they'll come back with an area of irritation or possibly ulceration. So 3 to 4 layers of distal proximal ends, 2 layers in the other areas overlapping half the width. And hopefully you have someone else helping you. I prefer not to have the parent. I prefer either your podiatry assistant or you can train your receptionist. But only the doctor manipulates the foot. So if I have the assistant, I show her exactly how I want her to position the foot as I wrap, and then I do the manipulation. Do not use too much padding. You'll notice that this is not as much padding as when you practice putting on a below-knee cast on each other. It's minimal padding and minimal plaster. Remember, this is a 12-pound baby who is not weight-bearing on this cast. And especially if you want the parents to sew off the cast, you can't make it too thick or they will not be able to sew the cast off. They come in with a damp cast and then you have to take out the cast cutter and the baby's crying, so you'd like to avoid that. Here, I'm showing wetting the plaster. I folded the end over, and now I'm squeezing the edges of the plaster roll. Not the center of the roll, but the edges. And make sure you fold it an end of the roll so that you can find it once the plaster's wet. Okay, so here I'm showing the roll. I folded the end over, and you will squeeze the edges of the roll. That's important to not have the roll turn into a banana or a cigar where you lose control of the roll and you have to cut it and throw it out. Okay, just like the padding, we wrap from the distal to the proximal end, and you want to leave about 1/4 to 1/2 inch of padding at both ends. You do not want the plaster right at the edge of the padding, and certainly you don't want it to contact the skin where it will cause irritation. So how do I check that the plaster is not too proximal at the proximal end? I have to lift up the legs and look at the back of the proximal thigh. So here now, I am applying the plaster. Notice, just like the padding, I am staying close to the foot. And here, just like with the padding, it's a little bit more on the proximal and distal ends, a little less plaster. You just want the cast thin enough so that the parents can remove it, but thick enough that it won't break in a 1 to 2 week period. They're not weight bearing. This is not on for 6 to 8 weeks. It does not have to be a really thick cast. And notice again, I am staying close to the leg as I wrap. Usually the first roll is from the tips of the toes to the proximal tibia. And now again, the student continues to wrap now, wrapping and staying close to the foot and leg. I'm holding the foot in a somewhat corrected position as she wraps. And we continue here. And usually the end of every roll, like I'm doing here, I'm leaving a little end, a little lump there, because when the parents soak it off, they're looking for those lumps so that they can find the end of the roll. So don't forget to leave a lump at the end of each roll.
Good. For today too. So
and now we come to the really important part. You want to manipulate the foot, and most of your correction is achieved by manipulating the foot after the first roll of plaster is applied. You could try to manipulate a little bit more after you put the second roll on, but the plaster is almost set, so most of the correction is in this part. Then, after you have that first roll, you can fold over your Surgitube or your stockinette, and in the second roll, you're going to seal that edge of Surgitube or stockinette. So here, now the student is starting the second roll. She's just quickly, not putting too much plaster on the lower leg or foot, because we already did that. She's working her way up to the groin area. And now at this point, we want to, because this is a club foot cast, we want to keep the knee flexed. I am laterally rotating the tibiofibular segment at the knee. And as she applies the roll, we want the middle of the roll, not the edge in the popliteal crease, again, to avoid skin irritation. And she's doing a very good job here. She's staying close to the leg. She is rolling the plaster away from the roll, not rolling it into the roll. Dr. Landau will show you that. It's a little more awkward when you roll into the roll.
Do you know what she means by that? Everyone? Yeah. Does everyone know what she means by that? So, just like with putting toilet paper on the roll, there is a proper way to do it. if this is the baby leg, this is what she means, like this. It's not like that, okay? It's gonna unravel if you do it like this. And this is with everything, even in surgery too. When you apply dressings, this is how you should be wrapping it, with the fatter part of the roll away from the leg, okay? That's what she means by that. You guys are gonna be putting it on in groups of 2 anyway, so hopefully one of you understands what that means, but I'll be watching also.
And now, as we move to the proximal end, we have to make sure that that plaster is not higher than the stockinette. We need to have an edge of stockinette.
Right, you see the roll is there, and this is piece, just like that.
We bring that up here. How often do I put on a new cast? Well, for TEV and convex pes valgus, ideally it's every 5 to 7 days. For metatarsoductus and calcaneal valgus, it's every 2 weeks. Okay? So you can keep it on a little bit longer, but ideally for the more rigid deformities, it's every 5 to 7 days. Okay. After the cast is applied, if you plan for the parent, or hopefully both parents, to soak the cast off, you first go over how to check the capillary fill time, and you touch the tips of each of the toes on the baby, and you show how it goes white for a second and then it goes back to pink. And this is especially important in the first 24 hours. When you're ready to the parent is ready to soak off the cast, usually the night before. If you have time with a clubfoot, especially, you can do it the morning of, because you don't want the pressure just before your appointment. We do use a mixture of warm water with vinegar, 4 to 1 water to vinegar. And when the baby is in the tub, if they're not sitting up, use one of those rings so that you can keep them in a sitting position. Let them play with their tub toys at least 20 minutes to soften the plaster. This is a lot of work. And then once it's softened, they're going to start that little lump you started and start unwrapping. Now, sometimes the baby may be very cranky. Or maybe the parent did see a change in the color of the toe. Or maybe the cast was applied too loosely and the mother calls you and says that I don't see the toes anymore. I think the baby slid up in the cast. Well, then you just tell them, take them right to the tub and remove the cast immediately and have them come back to the office. Now, the times I've had this when they were cranky, it was actually an ear infection and not the cast that was causing the crankiness, but better to be safe than sorry. Contraindications to serial casting, well, if there's skin irritation, that might be a possible contraindication. If they're very ill with a fever, I prefer not to, it's required. And prior to immunization, it may interfere with the injection sites. You want to check on when they're getting their next shot. Now we'll move on to metatarsoductus, and you're going to practice.
Okay, so everyone has something in front of them, right? Whether it's a baby leg or the stand with the leg.
This. So when you're manipulating a left metatarsoductus, it is your opposite right hand that cups the heel. Now, for you guys with big hands, I think you can just use your thumb and index finger and hold the heel slightly, neutral to slightly supinated. I have a small hand, so I cup the heel for better control of the baby when I do a manipulation. But whether you use your 2 fingers or you cup the heel on the lateral side of the foot, your hand must be proximal to the 5th metatarsal base. Now, why is that? Because if you hold your hand on the lateral side more distally with your right hand, and you go to abduct the foot with the left hand, well, your right hand is blocking the abduction you're trying to achieve with the left hand.
So what did she just say? Why does your hand have to be proximal to the 5th met base when you're doing abductus? Are you all zoning out?
You don't want to do it if you're moving in the midfoot. You want it. So.
You guys can't zone out. This is the test.
2 fingers, or you cup the heel on the lateral side of the foot, your hand must be proximal to the 5th metatarsal base. Now, why is that? Because if you hold your hand on the lateral side more distally with your right hand, and you go to abduct the foot with the left hand, well, your right hand is blocking the abduction you're trying to achieve with the left hand. So make sure you're proximal to the fifth metatarsal. That's important. It is also important to hold the subtalar joint neutral to even slightly supinated. If you leave the rear foot pronated and you abduct at the first metatarsal head, the foot will look straighter, but unfortunately, you are not really correcting the metatarsus adductus so much as abducting at the mid-tarsal joint and subluxing the mid-tarsal joint and creating a flat foot. You can see this on x-rays when it's done incorrectly. You have an increased cuboid abductus angle. You do not want to see that on an x-ray.
You're not writing down anything.
Make sure that the ankle of the plantar flex, the subtalar joint is neutral to slightly supinated. Don't let it be pronated. And then you're taking the first interspace of your left hand, pressed up at the first metatarsal head, and you are abducting, abducting. Keeping that heel inverted, very important. For a right metatarsus adductus, you are using your opposite left hand around the heel, and you're using your right hand on your right foot to abduct the foot at the tarsometatarsal joint by abducting at the first metatarsal head. So remember, it's opposite hand around the heel. If it's a left metatarsus adductus, it's your right hand around the heel. If it's a right metatarsus adductus, it's your left hand around the heel. Now, sometimes an older child with a metatarsus adductus is already walking. This is not ideal, but if you want to try it for a while, you can use semi-rigid fiberglass because the parent can unwrap it, and they can put a shoe over it and they can wear it. The problem with the plaster is if you put it on too thin, which we prefer, then they walk on it and then they break the cast. So fiberglass works out for that.
Okay.
Tarsus adductus.
We're gonna practice, okay? So everyone have a leg in front of them. She does same hand, same side, same hand, opposite side. That confuses me, okay? What shaped foot is a metaductus foot? It's a C shape, right? The forefoot is facing towards midline. So what do you think? When you're facing a baby, your inner hand has to be at the forefoot to push it out, okay? So where does that leave your other hand? On the heel. On the heel, okay? I can't do same hand, left hand, right heel. That confuses me always. If that works for you, great. That never worked for me. So, on a baby in front of you, I want your inner hand to be the interspace. It has to be at the MPJ. What do you think happens if it's only on the hallux? You're gonna create a bunion, right? It has to be at the MPJ, or a little bit proximal to it. What happens if you use too much force? You said it, John, before.
Turn at the midfoot.
Right, you're gonna make a midfoot subluxation. Writing this down, right? I think I just talked for my health. These are questions that I'm gonna ask you on the test, okay? Alright, so, I'm gonna turn on the lights briefly. Everyone has to show me. So, the inner hand is
Metatarsus adductus, it's your left hand around the heel. Now, sometimes an older child with a metatarsus adductus is already walking. This is not ideal, but if you want to try it for a while, you can use semi-rigid fiberglass because the parent can unwrap it and they can put a shoe over it and they can wear it. The problem with the plaster is if you put it on too thin, which we prefer, then they walk on it and then they break the cast. So fiberglass works out for that. And then of course our post-cast maintenance is open-toed straightless shoe, 23 hours a day for at least double the time required for the casting. So if it takes,
I know it's on the slide, but what happens after you're done with casting? Or 23, open-toed straight-lashed shoe for 23 hours a day. And for how long duration? I know it's not this. Double, good, okay, perfect.
takes me 8 weeks to correct the metatarsus adductus with serial casting, then it will be 16 weeks in the open-toed straight-leg shoe for 23 hours per day. They also have, ITT with the metatarsus adductus. You can, correct, both by going with an above knee cast. Or also you can just do below knee and then use a night brace, but the night brace is not 20 grams. The dog brace or the dental dog, that's just night at that time. Okay, so I am gonna have Dr. Landau, pause this video, and, you are going to practice these techniques on the dolls. So I'm gonna stop a minute and then, she'll resume, the, video. Okay. Now we're going to move on to the congenital calcaneovalgus deformity, the up and out deformity. Again, many of these in newborns may be mild and may self-correct, but by 4 months, if you're seeing a limitation to ankle plantar flexion, if you're seeing a high forefoot varus that's not reduced, tightness of the anterior structure, then that would be a good time to serial cast. Remember with the calcaneovalgus, the Achilles tendon is overstretched, and there are tight tendons across the anterolateral aspect of the foot and ankle. And although the whole heel is in valgus and the foot is abducted, in this posture of a calcaneovalgus, when you plantar flex and adduct the foot, you will often see, as in this clinical picture here, that there's a high forefoot varus, sometimes maybe 30 or 40 degrees. When we serial cast, we don't want to leave this forefoot varus in the cast, we want to reduce the deformity. So how do we perform this? Okay, so we want to plantar flex and adduct the foot. It's up and out, we want to bring it down and in. So we plantar flex the ankle, not too aggressively. Sometimes you can get sloughing of the anterior skin, especially in a younger baby. And you're going to adduct the forefoot. And once the plaster is on, you're going to mold the medial and lateral arches. That's important also in adductors. Molding in your medial and your lateral arches. Mold the Achilles tendon. So here I'm just showing you reducing the forefoot varus. You can plantar flex the first, but actually I like to just put my index finger on the top, my thumb on the bottom, and just put a valgus twist on all of the metatarsals, so it goes from a forefoot varus to a neutral position, where the plane of the metatarsals is perpendicular to the heel.
Okay, so this bottom picture here, does everyone have a good view of that? This one right here, she's twisting in plantar flexion in valgus because there was a forefoot varus present. So we just did metatarsus adductus, right? The hands are opposite now. So the forefoot hand isn't gonna be your inner hand, it's gonna be the outer hand. And then what does that mean for your other hand? That's gonna be on the heel, right? So this is a foot that's up and out, you're gonna stretch it down and in, and a forefoot varus is gonna be present. So now your outer hand is going to be twisting the forefoot into valgus and pushing it down and in, and you're gonna be gripping the heel with your inner hand and neutral to slightly supinating. So the hand, you know, positions change from metaductus to calcaneovalgus. Alright, so I'll walk around. I know that's confusing, but the more you practice with this later on.
Don't want to create a forefoot valgus or a canis foot. I just want to reduce the varus. So here's a videotape. This was during COVID when we were at home quarantining, and this is my grandson who's now 5, but here he was about 6 months old. And I can get very mild calcaneus foot posture, dorsiflex, which self-corrected. But I'm showing you here the manipulation of his foot. So here, it's up and out. Okay, I'm going to take my right hand, supinate the rear foot with my left hand, the lateral side. I'm plantar flexing and adducting the foot, so down and in. And then I'm just pretending you have the forefoot varus, and I'm just showing how you put the valgus twist. So you'll note with the calcaneovalgus that it's same foot, same hand around the heel. So with the right calcaneovalgus, it's a right hand, same hand around the heel, and then your opposite left hand comes from the lateral, onto the lateral side of the foot, not the medial, which is metaductus, We're coming from the lateral side and we're plantar flexing and abducting and then reducing that 4-foot bounce.
If that works for you, memorize it that way. That never worked for me, okay? I know everyone works differently. Because on the test, I know some of you guys repeat that back to me, and I just watch you do it, and it ends up being right. So whatever works best for you, okay? But she also showed you on the video how to position them as well.
After casting, we also use an open-toed straight-leg shoe. If it's an older child, where casting is not practical, we may use a UCBL, and certainly sometimes children have a very severe calcaneovalgus with underlying neurologic problems. We might use, as shown here, a supramandibular orthosis.
SMOs are for someone who you think a UCBL isn't going to be enough on. So it's very rare. It's for babies that have low muscle tone, where, you know, the flanges of a UCBL aren't enough, but you want it to go up higher because they're just completely collapsing, like severe genu valgum, ankle valgus, just very low muscle tone, very weak when they try to stand upright.
Okay, I'm gonna stop
Okay, so some
Again.
more questions on that.
here, and Dr. Landau is going to have you practice on the dolls, calcaneovalgus manipulations on both the left and the right foot. So I'm gonna stop for a minute, we're gonna keep stops for the video, and then we'll resume.
What was the reason? She said she didn't do it on her grandchild trial.
This was very mild. Yeah. If it's very mild, right, because there's a lot of brown fat in the foot, the little baby foot, especially in the arch, so it's really flat. Especially when they stand, it won't look like they have an arch at all, but if it's more moderate to severe, she would have done it. And he after it. This isn't a fun thing for a baby to do, and it's not fun for the parents too, especially if they're working. That's not a good work week for them, that those 2 to 3 months that you're doing this. It's, they're not sleeping much, because the baby's not sleeping much, you know? So, it was unnecessary, that's why. If it was a little bit more severe, she would've. Now, does her grandson, need custom orthotics at this point? I don't know, I haven't seen him in a while. Now we're doing club foot, okay?
Now we're moving on to the TEV. And unlike the metatarsus and calcaneovalgus, where if you get them at that ideal age, you get a beautiful result. 90% of your TEV babies will require surgical intervention.
How many percent? 90. Okay. Achilles tenotomy. It's the last step of the Ponseti casting technique, which is CAVE, the acronym. Cavus, abductus, varus, and equinus is the last one. You guys always miss that one on the test. 90% of them, the equinus does not get reduced, and they need an Achilles tenotomy.
You said it's cave and
C is cavus, A is abductus, V is varus, E is equinus. That's also boards too.
So briefly reviewing the 4 components of a TEV, we have the adductus, we have the ankle equinus, we have the varus, and many have a cavus element with a plantar flex first metatarsal. Should we treat? Well, this 86-year-old who was never treated for her left clubfoot, as we see this deformity here, obviously we do not want this type of foot, although I have to admit that the podiatrist who had fabricated a custom molded shoe, she did quite well with that, but this is not desirable. Look at that development on the dorsolateral aspect of the foot. So Ignacio Ponseti, he left Spain during the Spanish Civil War and he settled in Iowa. And he looked at babies and older people that had had the Turco procedure, an aggressive postural medial release, and he saw some problems with that later on, stiff feet, pain. And then he looked at Kite, who was doing casting for months and months and months, and he said, I want to come up with a better way of addressing a TPD. So his procedure involved minimal surgery, a shorter period of casting, and the goal of any clubfoot treatment is to have a flexible, pain-free foot with the ability to wear normal shoe gear. That would be the goal. Notice we don't say we want a perfect foot that's going to look exactly like the normal foot, because that's an unrealistic expectation. Parents would often say to me, I want my child perfect, I want the foot perfect. That's, in a clubfoot, that's not achievable. So he developed this. It took years for the medical community to accept this, but now it is considered the gold standard of treatment. And Ponseti said,
So how many above knee casts? 8?
No more than
Right, 5 to 8. Okay, how many go on to needing Achilles tendonitis? Okay. So, this bottom picture here, I'm gonna make you sequence them, okay? I don't like memorizing, alright? This leg here still has the adductus component, right? This leg at the end is the only one that's abducted. By cast 2, it's hopefully more parallel. Leg 2 is the only parallel one. Then when you get to leg 3 and 4, they're both slightly abducted, but leg 4 is more abducted than leg 3. And the last cast is the only one that doesn't have equinus. Right, so that's the series of steps. So I usually do the extremes first. Cast 2 is parallel. And then 3 and 4 are tough, you just have to look at them. And we're gonna do that right now. Everyone is gonna come up here.
after a maximum of 8 casts, if you do not achieve at least 10 degrees of ankle dorsiflexion, stop casting and go on to the Achilles tendon.
How much? Perfect.
And this will be about 90% of your TED babies that will require this. And Ponseti even said, usually after 5 casts, I can tell whether or not they're gonna require surgery. But if you close to correction, you could try the maximum of 8. Then, and this is where practitioners have found a little difficulty, it's years of splinting. And some babies do have problems with tolerating this. So here are 5 sequential above knee Ponseti casts. They're all right above knee casts. And this will be something you'll be doing on the test. We'll ask you to sequence these casts. And there are tricks to being able to do this. The first cast is the only one in which the right forefoot is adducted, abducted. The second in the sequence, the foot is parallel to the leg. The third cast, the foot is a little abducted to the leg. The fourth cast is more abducted to the leg. And the fifth cast is very abducted to the leg, ideally 60 to 70 degrees abducted to the leg. But it's
So, that line's very important for the splinting at the end with the brace. The goal result is to be 60 to 70 degrees abducted, because it always contracts a little bit back, right? So, the last cast, you want the forefoot to be how many degrees abducted? Exactly. Why? Because it was a club foot, it was severely abducted, probably 60 to 70 degrees to midline, right?
another way to tell this is the fifth cast is that the fifth cast is the only one that is dorsiflexed. 1, 2, 3, and 4 are all plantar flexed. So when Ponseti developed his casting technique, he wanted the practitioner to stabilize the talar head and then to move all of the other bones of the foot around the stabilized talar head.
Okay, what did she just say? What was Ponseti's goal? The talar head is gonna be very important during this casting, okay? Everything moves around the talar head, so what do you think we're always touching? The talar head.
Talar head. So the first element that he corrected was the case. In the next series of casts, he abducted the foot, and without touching the calcaneus, the heel moved from varus to valgus. Now, when he first introduced this, there were no MRIs, but later, when they were developed, it proved his theory correct, that as you abducted the foot, the heel moved to varus and valgus. And then the last element to correct, which most of the time you're not going to be able to achieve it, is the Aquinas element. And only attempt dorsiflexion of the ankle when you have abducted the foot so it's at least 60 to 70 degrees to the leg.
What did she just say? When do we attempt ankle dorsiflexion in the cast? Good.
Now, as a new practitioner, if you're having trouble visualizing that, take out your tractograph, use the zero, the one arm, bisecting the tibia, and then use the other arm and bisect the second metatarsal, second toe area, and then read how many degrees abducted. Only when you have achieved 60 to 70 degrees abduction do you attempt to dorsiflex. Probably the most common mistake in this technique is trying to dorsiflex the foot when you have not achieved 60 to 70 degrees abduction. So here we look at the models, 3 prominent bones. There's the talus, there's the lateral malleolus, and here's the calcaneus. Whether you're doing a one-handed Ponseti technique or using both of your hands to manipulate the foot, an examiner's thumb is always on the talus to act as a counter pressure as you move the other bones around.
What did she just say? Because we're gonna be doing one-handed or two-handed techniques, okay? One of your thumbs is always on the talus. And what are we not touching? The calcaneus. We are never, ever, ever, never, ever, ever touching the calcaneus during Ponseti casting versus the other two that we just learned about, right? That one we do cup the heel. We are not cupping the heel. We are touching the fibula instead, okay? So for Ponseti, you're gonna have to know one-handed versus two-handed technique, and we're gonna go through the differences now.
The talus. So the one-handed technique, which I think is technically easier to perform, Dr. Jonathan Herzenberg came to the college once. He teaches this technique all around the world, and he felt that the one-handed technique was simpler and easier to do, but I'll show you the two-handed.
And I agree, and this is the only time I do right foot, right hand, because it helps me. So if I said your thumb is always on the talus, and the first thing that we correct in Ponseti is the plantar flex first metatarsal, your thumb, just like she has it, your thumb has to be on the lateral head of the talus, and then your other index finger is pushing up on the first met, just as she's doing there. You it's kind of awkward, but your hand kind of has to be on the outside of the foot, exactly, so something like that. Something like this. So it's a right foot, this is my right hand, thumb on the outside of the talus, pushing up on the first met. So easy, right? Wait until we add the two-hand technique and that's when you start screwing it up. This is easy, right? So that's the first element. Thumb on the outside of the lateral head of the talus, index finger pushing up on the first met, that is the plantar flex first that we're correcting. That's the first step, okay? What are we doing with the other hand? Stabilizing the leg. It's one-handed technique, okay? So everyone show me that.
So on the side.
Yeah, exactly, just like that.
Or do that one, but I recommend one-handed. So in the one-handed technique, if you are doing a right club foot, you're doing all of your manipulation with your right hand, as shown here. So you can use the left hand up here and stabilize it, but I have my right thumb on the talus, and I am abducting the foot with my index finger on the medial side of the first metatarsal. So in the first pass, we are going to reduce the cavus element. Now, if there is no cavus element, you can start the first pass with abducting. But he wants you to first reduce the cavus. So this is a right foot, so I have right club foot, I have my right thumb on the talus, and I'm taking my right index finger and putting it on the plantar aspect of the first metatarsal, and I am just elevating the first metatarsal. And you'll know that you're doing this correctly when you see that the arch lowers. In the second pass, I still have my right thumb on the talus, but now I have my index finger on the medial side of the first metatarsal head, and I am abducting the foot.
So, it's no longer gonna be under the first met, it's gonna be medial, so what component are we correcting now? Right, the second, it's the A, it's the adductus. Now we're adducting the foot, that's why you have to push medial on the first met. Right, you don't have to memorize. What do we memorize so far? Same foot, same side, right? Thumb always on the talus, that's it. Does anyone have any questions on that, the second, step for one-handed technique? So instead of pushing up on the first met, the index finger is now just gonna be pushing medial. Exactly.
Notice I am resisting the urge to dorsiflex at the ankle. Not ready to do that. With the one-handed technique for a left foot, the first pass, the same thing, I'm elevating the first metatarsal. So now it's one-handed, so I'm doing everything with my left hand. I have my left thumb on the talus, and I am using my index finger to elevate the first metatarsal on the first pass, and the second pass and the subsequent pass, I am abducting the foot around that stabilized talar head by placing my index finger on the medial side of the first metatarsal. And here's a video which I'm demonstrating here on this little baby with the club foot. It's a left club foot, so I have my left hand on the foot, I have my left thumb on the talar head, index finger on the medial side of the first met, and I'm abducting the foot, abducting. Let's watch that one more time. Okay, it is on a loop. So it's abducting, and we are abducting, abducting. So that's the one-handed technique. And I'm gonna show you the two-handed, and then we'll stop, and Dr.
Okay, before we get into two-handed, everyone understand one-handed? Cause it gets confusing, alright, you ready? Okay,
Randall can have you practice the one-handed and the two-handed. Okay, the two-handed technique, as the name implies, you use both of, the examiner uses both of their hands. So now, if I have a right club foot, and you can see this has a cavus element, I'm using my left hand, so I'm using my opposite thumb. So if it's a right,
okay, so this is the biggest difference. For one-handed technique, your thumb is on the head of the talus, right? But now we're using two hands. So if you memorize one-handed technique as same leg, same hand, the head of the talus is used by the opposite hand for two-handed technique. And then your other hand is going to be pushing up on the first metatarsal or moving it medial, depending on what step that you're on. Okay, and then I'm gonna let her finish talking. So versus one-handed technique, same leg, same hand, thumb on the lateral head of the talus. Now it's going to be the opposite hand, because your other hand is going to be pushing up on the metatarsal now. Okay? Did that simplify it?
forefoot, I have my left thumb on the tail of head, I have my other fingers behind the fibula.
right? So this is a right baby leg. It's her left thumb that's on the lateral head of the talus. What are the rest of her fingers doing? Are they touching the calcaneus? Nope, it's right behind the fibula, exactly. And then what's her hand doing? Her right hand. Pushing up on the first med, right, that's the first cast. Cast 2, or once the arch is lowered, then we start addressing the adductus deformity. Okay.
Are you putting pressure on the tail head, on the, when you put it on the outside?
Yeah,
Okay, you're not just stabilizing?
well, there's some pressure there. You wanna push it back in. The goal of Ponseti, and he was right, it was pre-MRI and everything, it was pretty amazing how we knew this, that the foot moves around the talus. The talus is the center, and it is.
And then with my right hand, I'm just have my index finger on the top of the first med, thumb on the bottom, and I am dorsiflexing the first metatarsal to reduce the cavus deformity. With the two-handed technique on the right foot, after I reduce the cavus, I still have my left thumb on the talus, my other fingers behind the fibula, and now I'm grabbing the forefoot, grabbing second, third, and fourth metatarsal heads, and I am abducting the foot, abducting. Notice I'm not trying to dorsiflex, I'm not abducting from the medial side of the foot, I'm grabbing the distal end of the foot. Okay. For a left TEV, now again, I'm using my opposite right hand to putting my right thumb on the talar head, the dorsal lateral of the talus, my other fingers are behind the fibula, and here I'm showing grabbing the forefoot and abducting. The left hand manipulates the forefoot. So whether it's one-handed or two-handed, always keep a thumb on the lateral talus. Never touch the calcaneus. He does not want you to block the excursion of the calcaneus. And all casts are above knee. Even in the older child, when the parent begs you, if there's been a relapse and you're attempting Ponseti again, when they're 3 years old, it has to be above knee. And just remember, as you abduct the foot, the heel moves from varus to valgus without touching the calcaneus. So here is another video. This is a left TEV. This is the two-handed technique. Notice my right thumb is on the dorsolateral talus. My other fingers are behind the fibula. I'm grabbing the forefoot. Now here I'm showing the thumb on top and the other fingers on the bottom. Either way is fine. As long as you are abducting and grabbing 2, 3, and 4 med heads as you abduct. So it's adducted, you're moving into abduction. So here is a baby before casting where the foot was very adducted. Now after the 4th cast, it is abducted, but I could not achieve dorsiflexion in 8 weeks. So that means this baby went on to an Achilles tendon. It is a right TEV, as this dorsiflexion. This is post-tenotomy. This is not post-casting only, it's post-casting and then tenotomy. The Achilles tenotomy, you want to insert your scalpel.
I did one of these during residency with Dr. Godoy. It feels like celery.
From the medial side and anterior to the tendon. You want to be about 1.5 centimeters above the calcaneus, keeping the flat part of the blade parallel to the tendon. The blade is rotated, and then you just push back posteriorly, and you feel and hear a pop, but you're not cutting the sheath on the opposite side. And people worry about causing weakness, but actually ultrasound studies show that the tendon actually reestablishes continuity of the 2 stumps as early as 3 weeks after the surgery. And the calf diameters are equal, suggesting no decrease in strength. So here's a pre and post Achilles tenotomy. Closed Achilles tenotomy, and if you're asked on a board exam, Ponseti described a closed tenotomy. He even said this could be done without anesthesia, but I think we can certainly bring the baby to the OR and do this quick procedure while they are asleep. But he does say it can be done in the office. But, you know, there are risks, neurovascular damage and complete release pain. I'm sure it hurts when you make a cut. This was a study, where they did a mini open technique, so it's not a true pancreati. They made a small cut in that, they dorsiflex the ankle, they put a clamp on it, they make the cut, and then they injected it with epi. Not a little bit anesthetic, with epi. All right, I'm gonna stop here before I continue this lecture.
Okay, everyone show me two-handed technique now. So one-handed technique, if it's a right leg, it's going to be your right thumb on the lateral head of the talus pushing up. Now, two-handed technique, it's the opposite thumb that's gonna be on the lateral head of the talus, your other finger's behind the fibula, and you're pushing up on the first met with the other hand. So this is a right leg, exactly. Show me. Exactly. So that's one-handed, you wanna show me two-handed?
And she will come around and take a look, so.
Does anyone have any questions on metaductus, calcaneal valgus, one-handed, two-handed?
This one has, do plantar flex.
So it is a plantar flex first, right, we dorsiflex,
Oh, okay, so.
that's what the cave is, it's
For
the
something
cave,
about-
the C is, stands for cavus foot. We wanna get rid of the cavus foot by by dorsiflexing the first met that is in a plantar flex position. Exactly, you're pushing up on the first met. Cast two is going to be addressing the A in the cave deformity, that's adductus, so we're abducting. Cool? Yeah.
So, I'm gonna stop here for a minute, she's gonna stop the video, and then she'll resume.
Now we do baby hippie now. These hips are $1,000, okay? I don't want you to go full Monty on it, okay?
Okay, now that you've practiced your one and,
This slide's very, very important, okay? After the tenotomy, you have to put them in a Dennis Brown bar or a Dobbs brace. This is Dobbs brace, this is a Dennis Brown bar. Okay? How long are they gonna be in it for? 3 months all the time? This isn't a trick, it's up on the slide. 3 months all the time, then what?
4 years.
Okay, in either one of these. The Dennis Brown bar isn't much forgiveness, right? It's a straight up bar. It's not real, they don't really tolerate it well. At least with this one, the Dobbs brace, they can kick a little bit. You know, there's some forgiveness in it. Okay? Notice what's with it. What's with it? A straight latch shoe. So how do you think you write the prescription? An open-toed, straight latch shoe, Dobbs brace. How do we figure out the width? Their shoulders plus 2 inches. Shoulders plus 2 inches. For a club foot, what do you think the baby also needs in addition to this? For the same reason that we have to do above knee casting. They need an AFO with it on the club foot side. They don't need an AFO for the ITT side or the unaffected side. Baby club feet need an AFO with the straight latch shoe. Why? Because of the Aquinas deformity. Okay. So how long do they need a dog brace for? Right, so 3 months all the time, 2 to 4 years only at night. Who needs the AFO? And then what does metaductus need? They both need open-toed straight latch shoe, but metaductus just needs open-toed straight latch shoe, or ITT. So Dobbs brace fixes clubfoot and ITC and metaductus, right? It's transverse plane stuff also. But the one that needs the AFO is the clubfoot because there's a sagittal plane component. If there's no AFO, they're gonna come right out.
And two-handed. What do we do after casting Achilles tenotomy? Well, this is where it becomes some difficulty. Practitioners, I certainly found it with a really young baby. They need to be braced 3 months all the time. You know, give them a bath pretty much 24/7. And then 2 to 4 years night. And as you can see, the feet are very, very abducted here. And even the little ones have trouble tolerating this one, but that is the strict concept. So ideally, we want to,
This is very important. I don't like to memorize, right? The last cast in Ponseti, before we do dorsiflexion, how many degrees abducted does it have to be? 60 to 70. What a coinkydink that that's also how much transverse plane deformity you have to put in the dog's brace. You abduct the foot on the bottom. There's degrees on the bottom. Some of you guys, when I was at 9S, when you came with me, we almost had to change one, but the place did it right. Was that with you? Yes. So on the bottom, it tells you the increments, and for the clubfoot side, you want it to be 60 to 70 degrees. The normal or unaffected side is gonna be what? And this is what you're gonna have to do and write for your Peas bar test. That's why, you know, you guys try to get me to sign it off and I was not going to. It has to be legitimate, right? Which one needs the AFO? Who needs the open toe straight lat shoe? Good. Feel good?
take your dog's brace or your Fran bar, whatever device you're using, you want about 60 to 70 degrees out toe on the clubfoot side. Now, in the OR, once you did the tenotomy, if you see you only got 60 degrees abduction, I would just set the bar at 60 degrees. If you got 70, I would set it at 70. Now, if you have a unilateral clubfoot, you still have to set the clubfoot side at 60 to 70, but the normal side can be just 30 to 40. This baby here had bilateral, so both feet are very, very turned in. Now, if you look at the literature for the dog's brace, the width usually is from mid-heel of the left foot plate to mid-heel of the right foot plate. That should line up with the shoulder. However, for better tolerance, when using a night brace for a clubfoot, I would add 2 inches. So if I measure the shoulder width at 6 inches, I would dispense an 8-inch bar. It's a little wider and they tolerate it better. Now, Don spoke to Ponseti at the end of his life, and he lived, I think, into his 90s. He explained the problem we practitioners were having with tolerance of the stiff bar. And he designed a more flexible bar, which of course he named after himself. And Ponseti kind of approved at the end of his life, accepting it, but Don was worried that with this more flexible dog brace, which is better tolerated than the stiff, dense brown bar, that it might not control the equinus, but there might be a recurrence of the equinus. So if you use a dog's brace after clubfoot treatment, always use an ankle foot orthosis with it. I just use a solid AFO. I want to really make sure that the ankle does not go into plantar flexion. And this was a baby, this was a postural clubfoot, born to a very young mother, a large baby, and I was able to correct this without any surgical intervention. So I did the casting, I got the dorsiflexion using the Ponseti technique, and then I prescribed, as you can see here, a solid ankle foot orthosis, just with a, not a full-length foot plate. It's easy to get them into the straight leg shoes. And I used that not for 2 years. I maybe did that about 6 months. You can use a shorter time if you had a mild postural clubfoot that did not require surgery. But if it's your typical 90% of the time idiopathic clubfoot, if you had to do surgery, then you do want to splint them a long time. And just keep in mind that something the parents forget, that surgery is just a moment in time in the treatment of your clubfoot patient. Even the most reliable parents, I would find that after the surgery was done, they didn't come back to the office. They didn't think they needed the follow-up, and they didn't come back. And this is when you get the relapses. You have to follow them for years. And here is a protocol. Once you start the bracing, you have to come back in 2 weeks, basically to just check, are you wearing it all the time? Except when giving bath. Then, after the 3 months of wearing it all the time, they come back, and then you check on them again, and then you tell them night and nap time. And you can tell them that earlier, but just bear with us for 3 months. And then until age 3, it's every 4 months, and age 3 to 4, then about every 6 months. And then, if they're more than 4, maybe every 1 to 2 years. You want to catch those relapses early. So here is one of the patient that came in last year from France and had, from the description, we had one of our students who can translate. We have many bilingual students here, and she was great. And from what she translated, I basically understood that it was the Ponseti technique. You can see this is a different type of bar with just a polypropylene AFO attached to the bar. And they were just back for a follow-up to see how well the foot was doing. And as we can see from the x-rays, quite well. This looks great. This is I don't see a 4-foot adductus. I see a divergence of the talocalcaneal angle. I don't see a narrow TC. I see a relatively really normal TC. And on the lateral, again, I don't see a parallelism of the 2 bones. I don't see a calcaneus pitch downward. I see a talus that's a little plantar flex. And this is actually great alignment. And we were able to assure them you're doing great. Now here's a case which you're going to encounter is a relapse. This was a 17-month-old male who came to the clinic basically because he was walking funny, and his clubfoot had come back. So he had been casted following Ponseti, had the tenotomy. He did not tolerate the AFO or the knife brace, so they were following the dog's protocol, but he didn't come back for months. And when we examined him, he was negative 20 degrees at the ankle.
So, what do you think? You go through Ponseti one time, right? Baby comes back, you don't see them for a while, they have negative 20 at the ankle. What do you do first? What did Dr. Asek just say? You recast them again, right? If that doesn't work, then what are you gonna do? We're gonna do the tenotomy, okay? Because it's negative 20 degrees at the ankle. Now, I don't know if she talked about it yet, what happens, you do a round of Ponseti casting on a kid, they did fine, you discharge them at the 4-year mark, and then they come back at 5 years old, and now they're walking on the outside of their foot. It's the dynamic supinatus going on. What do you think? I think she explains it in a second. Think about
If you
it.
watch him walk here, you can see that the way he gets his heel down is he hyperextends the knee. And that's not desirable. So, in this case, we resumed Ponseti. Again, you can do it up till about, for a relapse clubfoot, up till about 5 to 6 years of age, you can attempt casting again. And although we corrected some of the relapse adductus, it still did require another tenotomy. Now here's what we've shown here, where I repeated surgery. This was one of the final tears, but you can see the foot is plantar flex at the ankle. So Dr. Jules did another tenotomy. Okay, now here's another baby who had Ponseti twice. She had been casted in Rhode Island. She moved to New York. We had to start the casting again. And she was a pretty reliable patient. But after the surgery, she never came back. We called, got no response. And just 1 month after we dispensed the Dobbs brace with the AFO, she stopped using the Dobbs brace because the shoes got too small, and I couldn't prescribe a bigger pair of shoes. But, 7 months. She did, however, keep the AFO on. And the main reason she came back was now that the child was trying to walk, and they will slip on the floor. You can't wear a slippery polypropylene AFO without a shoe over it. So in this case, the dorsiflexion was still good, even though she didn't wear the night brace, and I think that's because of the AFO. In this case, we're not gonna do another tenotomy because the ankle dorsiflexion is good, but we, told him to continue the AFO with a sneaker over during the day, and we tried to get it back into the night brace. Very hard though, once they've been out of it for 7 months. So we tried that, and, you wanna always emphasize the problems of relapse, and they have to follow up. You wanna catch those early.
This is what I'm talking about. So, you do Ponseti successfully, patient comes back, these are 2 complications, by the way. So the reoccurrence of the equinus, you wanna cast away, attempt to, before you do the Achilles tenotomy. This other complication is called dynamic supination. So they can come back after Ponseti and they're walking on the outside of their foot. So what you wanna do is the tibialis anterior tendon transfer to the lateral cuneiform.
This is from earlier. You also did you say you also did the Achilles tenotomy before the 4th pass? If you can't get the reduction to 60 to 7?
No, the Achilles tenotomy happens at the end. If you can't get to +10. You don't start dorsiflexing unless you can get the foot abducted to 60 to 70. Does anyone have any questions about dynamic supination? Because I am gonna ask you that.
So tibialis anterior transfer to the,
Because the foot, you're walking on the outside of the foot. Tibialis anterior tendon is pulling too strong. You cut the tendon in half and you put it on the outside of the foot. So you're not walking on the outside anymore.
okay,
It's called a stat procedure once you get to surgery. We're just describing what it is. Okay?
Wait,
Another,
but she said you should use an AFO to help avoid recurrence of equinus for, but in the Dobbs brace, is that right?
Yeah,
Or is
that's-
it the straight?
That's what we just did, yeah.
Okay, yeah.
Inside, the Dobbs brace is just the brace. You have to also order straight leg shoes and the AFO. if
So you have a
needed.
straight leg shoes
This is
and
what-
the AFO?
This is a straight leg shoe,
And then they'd have that and the AFO, or would
and the
we
AFO on the
aiming
side.
at- Okay, okay.
They're wearing the AFO because of the Aquinas.
Okay, I didn't know if it was like double or if you're just doing the AFO instead of the.
Right, so the brace has to attach to something. And the same with the Dennis Brown bar. Dobbs brace, Dennis Brown bar. That's exactly how you have to write it. If you don't write straight leg shoes, they're not gonna give it to you. They're just gonna give you a brace.
Dr. Nanda, which one are you, more likely to prescribe?
The Dobbs brace is more tolerable because they can kick.
Okay, so they don't use that much?
No, this one's like a torture device, right? There's no give to it at all.
Okay.
You can't kick, right? This gives them the illusion of freedom.
component of, the Ponseti technique, which he still views as not a complication, is that about 10% of the kids, when you perform the Ponseti technique and the tenotomy, when they hit 3 to 4 years of age, they start showing a lot of dynamic supination. They start walking with the heels embarrassed, walking on the plantar lateral aspect of the foot, and if they're still young enough, I'm talking about 12-year-olds, then you can take the tibialis anterior tendon and you can transfer it to the lateral cuneiform. This weakens it as a supinator, and this is still a minimal surgery, not bone surgery, that can correct this. So keep that in mind. This is a great, global health, if you Google Global Health Clubfoot on setting management, the 3rd edition. This is translated into many languages. I know our Canadians like to read this in French. It's a very practical manual. I'm not saying you have to read through the whole thing this busy junior year, but maybe if you have some time as seniors, it's a great reference and you can pull it right up and download it. Just wanted to show you this quick, interesting case showing you just have to have great general knowledge and attempting. This was x-rays of a patient that a podiatrist sent to my husband and asked him, can I do metatarsus adductor surgery on his foot? But on further history, Dr. Q ASAC elicited the information that the so-called metatarsus adductus didn't start till 11 years of age. Now, that's suspicious, that's a red flag. Metatarsus adductus by definition is congenital. Also, although he cut out some of the important aspects of the x-ray, this is not a metatarsus adductus. Look at this high calcaneal pitch. That's a Cavis foot. And although he cut this off at a very, very narrow TC angle of about 5 degrees, that's not a metaductus. Metaductus by 12 would have a very increased halo calcaneal length. You have a narrow TC angle, a 4-foot adductus, and a very, very high calcaneal pitch. This is an acquired cavo-adductovarus foot. And his brother, his younger brother, is developing the same acquired cavo-adductovarus foot. So the first thing you want to do before you consider any surgery, not metatarsus adductus surgery, because it's not a metaductus, is to have the children consult with a pediatric neurologist. And this turned out to be a filiform neuropathy. So any acquired clubfoot deformity, you want to have that checked. We now move on to the hip examination, and we have baby hippies that duplicate pretty closely what it would feel on a live baby. You would probably be a little gentler on a living baby than on the hippies, but it will give you the feel.
Okay, so for these two maneuvers, your thumb's gonna go exactly how she's showing it. On the inside of the thigh, and then the rest of your hand on the greater trochanter, okay? Hip abduction is a stable position of a baby's hip, okay? You guys will each get to practice on this, on the baby hippies, but they're $1,000, okay? I know she whips it fast, in the video. That's because she has experience with this, okay? I don't want you to break the head off of the femur. It probably happens once every 2 years, and then we have to buy another one, okay? So, for Barlow's test, is it dislocatable? Can you push it out? Okay, so, with that being said, you're gonna put your thumb on the medial thigh, and then your other parts, your other fingers on the lateral thigh, and you're gonna apply pressure in hip abduction, and the hip will pop out.
And I said earlier, on these models, the Barlow test is always performed on the baby hippie's right hip, and the Ortolani is always whatever the manufacturer on the left hip. So remember we said Barlow test, is the hip dislocated? So can we pop it out and pop it back in? So you want to have the baby on their back with the hips and knees flexed. You want to put your thumb on the medial thigh and your other fingers on the lateral side, and particularly your index finger should be on the greater trochanter. And you're going to push down on the leg, as if you're pushing the leg into the table. Okay, so let's see a video of that and see what we mean by that. Remember, only do this in the first 3 months of life. This is not valid. Neither the Barlow or the Ortolani is valid after 12 and 2 months of age.
Right, so
And
this is
we're
gonna
gonna
be
test
on
like it, but
an
it's
infant,
for
right?
people to understand. So here I'm showing the Barlow maneuver in this video on the baby hip. So my thumb is on the medial side, my left index finger is on the greater trochanter, and to pop it out, I'm going to adduct the hip and push down, and you will feel the head slide out of the acetabulum. To pop it back in, I'm going to do 3 things. I am going to pull up the hip, I'm going to pull up on the leg towards me, I'm going to abduct the leg, and I'm going to take my finger on the greater trochanter, and I'm going to push the greater trochanter back into the hip socket.
Okay, so, for those of you that wanna practice on the leg, come up here now. So it's the baby's right leg.
Videos that are all on canvas, and I'm going to stop for a minute, and Dr. Landau's going to stop the video while you practice on the baby hippie, and then you're going to come back to showing a video of me applying an above knee cast on a baby with metatarsus adductus. Okay, so I'm going to stop here and pull up the second video. This is a good time to stop.
She's gonna start in a second. I'm just getting the stuff big anymore, so we're just more efficient, which is my middle name.
Stuff for
I love that part. I miss them. I really, really do.
Okay, so now I'm going to show you the application of a cast on a live baby. Here I'm showing the betadine solution, and I'm showing the stockinette. And here I like the Johnson & Johnson Specialist Cast Padding. Other people like Rebel. I like that. Okay, fitting. I've got scissor here, some faster. These are 2-inch rolls. Make sure you can fold the end of that roll over. Here are 3-inch rolls, a bigger baby, and a basin, and really just warm water, not hot, not cold.
And we collect them in stands too.
Now I'm showing a very cooperative baby. I had casted this baby about 6 weeks already. So you really don't see very much of this initial severe metatarsal structures and internal tibial torsion that the baby had. But I was applying a cast, and we decided to do a videotape of this really cooperative baby here. You don't see too much of this, but you'll still get the idea of the casting technique. Right now, there's very little turning of the leg. We had done above knee cast, and we had turned the lower leg out on the thigh at the knee, and very little
Come
turning.
back for those in a second.
Okay, so now I'm manipulating the foot. I am cupping the heel, but notice I am proximal to the fifth metatarsal base. I don't want to be too distal with my opposite right hand and my left hand at the first metatarsal head. Do not push over the hallux, that can create a bunion. And we have high IM, and then you push over the hallux, go back.
Thank you.
So I am abducting, abducting at the first metatarsal head as I keep back heel neutral to slightly supinate. You can leave the ankle slightly plantar flex unless you're doing this on a walking child. Then the ankle has to be at 90, but that's not so ideal. Once they're already walking. And abduct. Sometimes you can put a valgus twist if there is a 4-foot varus, but this is encountered more commonly with calcaneal valgus, not with metatarsal valgus. Okay, and I'm abducting. I keep my wrist straight. I am putting some force on that, but it does not hurt the baby. Here, I'm just showing, babies this young have a lot of transverse rotation at the knee, but there is even more transverse plane rotation with the knee flexed than with the knee extended. I'm just showing there's a lot of rotation, there's some but a little less. But another reason we do above knee cast with the knee flexed for metatarsal adductus is it makes it harder for the baby to slip out of the cast with a flexed knee than an extended knee. And I also want to do it because I have more transverse plane motion, because if you're correct in ITT, you're going to rotate the lower leg laterally on the thigh, and then keep the cast on in that correct position. Here, I am applying the thin layer of betadine solution, not scrub, from the tips of the toes all the way to the groin. And notice he's very, very happy, but we still, in your office, you want to be ready to go with this. Not a half-hour registration, not a 20 minutes getting supplies. You know a baby's coming in with this, you want to be ready to go, because even the happiest baby will get bored and tired after a while and get fussy. So the faster you can do it, the faster you prepare for it, the faster you can go. Now I have a 2-inch stockinette. I'm going to apply that to the leg. Work with them as they wiggle around. Notice I didn't put plaster, I didn't put betadine on the right leg, on just the left, so it's on this line. And then a second piece on the foot, I have left the answer ankle free. And now I'm taking my Johnson Johnson Specialist Cast Padding. I am wrapping, as you can see, away from the roll. And I'm starting at the distal end. When I did this video, I used to make the cast a little more proximal. I do go more distal now, just so I see the tips of the toes. I've changed my technique a little bit on that. Notice I am rolling close to the leg. And I'm coming around. Remember the shape of the heel and foot and ankle. Sometimes you'll miss that heel, so you gotta look behind, make sure you got the heel. And then we'll continue to roll up the leg. I tear it somewhere in the middle, and I continue up the leg. You continue here, go toward it. Remember the middle of the roll, not the edge of the roll, into the popliteal crease. I mean, the baby's happy there with the bottle, but I want to keep working here because finish that bottle. We want to try to time it. And the middle of the roll, popliteal crease. The assistant is keeping the knee flexed and
You're gonna see
rotating
how to
the leg
unravel.
laterally as I
It's
do
gonna
the
be
wrapping.
for both the
And we'll
web
have a
roll
little bit
and
more
the
of the
plaster.
padding on the proximal and distal ends. Just a little bit more in that proximal end. And we'll look behind the heel and make sure I didn't miss a spot. Very important. Now I'm taking my plaster, fold over the end. Once you wet it, if you don't fold over the edge, you can't find the edge. So make sure you fold it over, get it really wet, but make sure it's wet in the center.
Which sides do you squeeze out?
Good enough. And squeeze the edges of the roll, not the middle. Squeeze it just like that.
You won't be able to
Feel the
unravel
edges.
it, I promise.
You don't create a banana with the plaster and throw
If
it
you
out.
don't do it exactly like this, you won't get it. And then you have to throw out the roll.
Now, I'm gonna start the roll, close to the foot, maybe about 5-6 layers around the, forefoot,
Today, we don't have to do that,
and then I'm
okay?
gonna work my way up. The first roll, as I said, usually goes up to the tibial tubercle, and then you work your way down. I usually don't go above the knee until I start the second roll. Now, if somebody has a little beta gun on, that's those purple spots. We put slightly more tension on the foot, and we put slightly less tension on the leg.
3,000.
Once that first roll is applied, that is when we're going to achieve most of our correction with the manipulation. You know, sometimes parents will say at the first test, well, it looked great, but then the next morning it came back a little. Yeah, you're not gonna get 100% correction in just one test. But we'll relax for a minute. Okay, I'm keeping my right hand on the left heel, keeping it neutral, slightly supinated. I am abducting. I'm keeping my left wrist straight, so I have my forearm straight, and I am abducting, abducting. I'm also going to mold my lateral arch and my medial arch. My assistant is pulling the stockinette back, so I can see the toes. And again, right now, this goes, application of the cast. But you can only see the tips of the toes. So sometimes you do go properly, they grip the toes, they get blistering on the top of the toes. That's not desired. I am molding in that medial arch as well. I don't want to create a flat foot, I just want to correct the metatarsus of the foot. Molding that there. Get a nice correction. And again, molding, and you can see that we have a nice foot. I actually would go slightly over-corrected past a straight foot because these relapse movements, if you go just slightly over-corrected and come back slightly, you got a perfect foot. Now we pulled over the edge of the stockinette and we are starting, our assistant is starting the second roll, sealing the edge of the stockinette, and she's going to put a little bit on and then work her way up to the thigh. great variance.
Well, this is a boy one, they were all girls.
Also, don't make the cast too smooth and perfect, leave a little roughness, because that is easier for the parent when they're trying to take off the cast. Leave a little rough edges, leave a little lump at the end of the roll. Don't make it perfect glass smooth, it's harder for them to soak it up. And here, we're coming up again, and now she's going to use the middle of the roll and the top two feet. Oops, she lost control for a second. And really stay close to the leg, she's too far away, try to roll it directly on the foot and leg. Now we're working our way up. Now remember, we have to look on the back of the thigh to make sure that the plaster is not coming up higher than the padding. That's important. Okay, now we folded the proximal end of the stockinette back on itself, and now we're putting a final half a roll to seal that edge. You'll notice that the knee is flexed. The foot is really lateral to the thigh because we have rotated the tibio-fibula segment. We're correcting the internal torsion component. Left the lump here at the end, and now we're just letting it set. By this point, you're not trying to correct the foot anymore. That is set. I am just trying to maintain the knee flexion. You really need them cooperative, because if they really kick a lot and try to fight you, it makes it more difficult. And I didn't show the second leg. The tibial torsion was really corrected on the milder right leg, so I only did a below knee on that. But we can see that it still looks like a foot and leg. It doesn't look like a giant wall of plastic. You put too much plaster. The foot is lateral to the thigh because I laterally rotate the tibio-fibula segment. We can check the capillary fill time of the toes. There's a nice lump where mom soaks this off. And we have a nice correction. I think this was the final cast we did on this baby. Notice also the ankles are a little plantar flex, the child's not walking. Notice the Achilles tendon is molded nicely. We have a well contoured arch in the lateral side. And this was a great baby, and we do both legs. We spend more time for the reporting, and we only cry here at the end. That was enough for them. Okay.
Any of you guys get to see this
Back
yet?
here.
No, yes, you did?
Sharing.